Okay. Good evening, everyone, and welcome. Today's workshop will be diving into trauma-informed care. This session is designed to deepen your understanding of trauma, not just as an event, but as an experience that shapes behavior, emotional responses, and engagement with care systems. By the end of this training, our hope is that you leave here with a stronger, more compassionate framework for working with clients, colleagues, and communities, your loved ones who carry trauma histories, whether known or unknown. So, thank you for being here and choosing to build safer, more supportive spaces. My name is Harsh Deshmukh. I'm a psychologist here at MindTribe, and I work with a lot of clients ranging from anxiety, depression, relationship issues, academic issues, and so on. Along with me, I have Shubhangi. Shubhangi, you can go ahead.
Hi, good evening, everybody. Thank you so much for joining in. I'm Shubhangi, and I work as a senior psychologist with MindTribe. I welcome you all to today's workshop. I'm trained to deal with issues such as anxiety, depression, trauma, self esteem issues, relationship issues, so on and so forth. It is lovely seeing you all here. Over to you, Yash.
Hello.
Dr. Sandra, if you could please keep your mic off.
Sure.
Yeah, thank you. So, before we begin, a quick disclaimer. All the content in this presentation is the intellectual property of MindTribe Healthcare. I request that you please refrain from recording the session or taking photos of the slides. You're absolutely welcome and encouraged to take notes for your own learning and reflection. Thank you for so we can maintain a safe and focused learning environment. Okay, so we'll begin our workshop by grounding ourselves in the fundamentals, right? Understanding what trauma is. Before we look at care, interventions, or best practices, it's important that we build a shared language around trauma, its forms, and how it shows up in the people we work with. Right? This first section will set the foundation for everything that follows. So, when we talk about trauma, we are referring to the emotional, psychological, and even physiological response that occurs when an experience overwhelms a person's ability to cope. It's not just the event itself, it's the lasting impact it leaves on the mind and body. Trauma is about the felt sense of threat, helplessness, or lack of control. This is why two people can go through the same situation and have completely different reactions. The meaning the experience holds for them matters just as much as the event. Trauma can occur as a single incident, like an accident, assault, or sudden loss, but it can also develop over multiple experiences, especially when those experiences are prolonged, repetitive, or unavoidable. This includes things like childhood neglect, domestic violence, bullying, or living in unsafe environments. Many individuals don't experience just a form of trauma. Their histories may include several layers of distress, developmental trauma, relational trauma, or chronic stress. These layers interact and shape how they see the world and how they show up in relationships. And finally, it's essential to emphasize that trauma is ubiquitous. It's far more widespread than we tend to assume. Whether we work in healthcare, education, corporate settings, or community spaces, we are interacting every day with people who carry trauma, often silently. Recognizing this helps us shift from what's wrong with this person to what has this person been through and what do they need to feel safe. Right. So when we interact with individuals who have experienced trauma, it's important to remember that trauma doesn't always show up in obvious ways. Often it appears through patterns of behavior, emotional reactions, or even physical complaints that may not immediately uh, seem connected to a traumatic history. The first sign is irritability. People with trauma may appear easily frustrated, impatient, or reactive. This isn't because they are difficult, It's often because their nervous system is operating in a heightened sense of alertness. Their body is constantly scanning for danger, even in safe environments. Second, flashbacks or reliving. This can range from vivid, intrusive memories to a sudden emotional shift that seems out of proportion to what's happening. Sometimes the person doesn't even know why they are reacting the way they are. Their body is reliving a past threat in the present moment. Third, physical symptoms. Trauma lives in the body as much as in the mind. People may report headaches, sleep issues, stomach problems, pain. These aren't imagined symptoms. They are very real and often a sign that the body is holding unresolved stress or fear. And finally, emotional dysregulation. This refers to difficulty managing emotions. Someone might have sudden mood swings, struggle to calm down once activated, or feel overwhelmed by feelings that other people seem to handle easily. Trauma can compromise the brain's ability to self soothe, making everyday stress feel unmanageable. Each of these signs reminds us that behavior is communication. When we see these patterns, instead of judging them, trauma informed care asks us to get curious about what the person might be carrying. Oh, sorry, I think uh, my screen stopped sharing. Right, is it visible again? Okay. Uh,
Okay, sir.
Hello. Uh, yeah. So to deepen our understanding, it's helpful to look at the different types of trauma. Not all trauma look the same, and the way it impacts someone depends a lot on the nature and duration of what they've experienced. First, acute trauma. This comes from a single overwhelming incident like a car accident, a medical emergency, an assault, or a natural disaster. Even though it's a one time event, the emotional shock can be intense and the effects may linger long after the incident has passed. Second, chronic trauma. Chronic trauma comes from repeated and prolonged exposure to distress. This includes situations like ongoing domestic violence, long term physical or emotional abuse, repeated bullying, or growing up in an unsafe environment. Here, the body and mind adapt to constant threat, which can lead to persistent hypervigilance, distress, and emotional exhaustion. And finally, complex trauma. Complex trauma involves exposure to multiple varied and often invasive traumatic experiences, usually occurring in childhood and within close relationships. These are traumas that happen in the context of care, caregivers, family members, or trusted adults. Because the trauma is interpersonal, it deeply affects a person's sense of safety, self worth, and their ability to form healthy relationships later in life. Understanding these distinctions matters because the type of trauma shapes the kind of support a person needs. Acute trauma can create sudden shock, chronic trauma rewires survival patterns, and complex trauma shapes identity at its core. So, when we think of trauma incidents, we often imagine only the most extreme or visible events. But trauma actually comes from a wide range of experiences, and its impact depends on how deeply an event overwhelms a person's sense of safety and control. Some common trauma incidents include sexual trauma, experiences of sexual assault, harassment, or violation can have profound and long lasting effects. These incidents can disrupt a person's sense of bodily autonomy and trust in others. Second, childhood trauma. So, events like neglect, abuse, parental conflict, or growing up in unstable environments. What a child lives through often becomes the foundation for how they understand the world and relationships. Then we have death, whether it's the loss of someone close or witnessing death unexpectedly, it can be deeply destabilizing and emotionally overwhelming. And lastly, witnessing a traumatic scene. Even if the event didn't happen directly to the person, being present during violence, accidents, or crisis can be deeply traumatic. The body still absorbs the fear, confusion, and helplessness. But the most important point here is this: trauma can be anything. It doesn't need to be dramatic or life threatening to be traumatic. Any experience that shakes a person's sense of safety, stability, dignity, or control can leave a lasting impact. Trauma is defined by the person's internal experience, not by the event itself. Now that we've explored what trauma is and what forms it can take, now we are going to look at how people typically respond to trauma. These responses aren't weaknesses or personality traits, they're survival mechanisms. They come from the body and brain trying to protect the individual in moments of overwhelming stress. Understanding these responses helps us create safer interactions and avoid misinterpreting someone's behavior as resistance, defiance, or disinterest when it may actually be a trauma response, right? So, when someone is feeling overwhelmed or perceiving a threat, whether real or remembered, the body automatically shifts into survival mode. These four responses: fight, flight, freeze, and fawn are instinctive and they are all normal human reactions to danger. First one is flight. First one is fight. The fight response is the body preparing to protect itself through confrontation. This can look like visible anger, a raised voice, irritability, or emotional outbursts. Physically, you might notice clenched fists, a tight jaw, crying from overwhelm, or a burning sensation in the stomach or chest. It's not about aggression, it's the nervous system saying, I need to defend myself. The second one is flight. Flight is the urge to escape the situation. People may appear restless, fidgety, or anxious. Their eyes might dart around, their breathing gets shallow, or they may constantly move their legs or tap their feet. This response communicates, I need to get away to feel safe. Third one is freeze. Freeze happens when the mind and body shut down to survive. A person may feel stuck, disconnected, numb, or spaced out. They might hold their breath, feel heaviness in their limbs, or struggle to respond even when they want to. Freeze is the body saying, if I can't fight or run, I'll shut down until it's over. And lastly, we have fawn. Fawn is often overlooked, but it's extremely common, especially in relational trauma. Here, the person tries to appease or please others to prevent conflict. They may over apologize, have difficulty saying no, minimize their own needs, or immediately take blame. This response communicates, if I can keep everyone happy, I'll stay safe. These responses aren't choices, they're automatic survival strategies. A trauma informed approach helps us see these behaviors with compassion rather than judgment. The question becomes not why are they acting like this, but what might their nervous system be trying to protect them from? As we move forward in the next mini section, we are going to focus on something incredibly important: the conditions that commonly occur alongside trauma. Trauma doesn't exist in isolation. It often intertwines with other emotional, psychological, and physical challenges, shaping how a person functions day to day. Understanding these comorbidities helps us recognize that what looks like anxiety, depression, or behavioral issues may actually have trauma at the core. This awareness allows us to respond with more accuracy, compassion, and effectiveness. So, when we look at individuals with trauma histories, we often see other psychological conditions developing alongside the trauma. These aren't separate issues, they are interconnected responses to prolonged stress on the mind and body. Firstly, we have PTSD or post traumatic stress disorder. It is the most widely recognized trauma related condition. It can involve intrusive memories, nightmares, avoidance, hypernumbness. But not everyone with trauma has PTSD. Trauma can manifest in many other ways too. So, secondly, we have anxiety. So, chronic worry, fear, and physical symptoms like restlessness or panic attacks frequently emerge after trauma. The nervous system remains on high alert, making the world feel unpredictable or unsafe. Then we have depression. So, trauma can lead to deep sadness, loss of motivation, withdrawal, hopelessness, or feeling emotionally flat. It can arise from exhaustion, unmet emotional needs, or the belief that one's experiences are too overwhelming to process. And then there are many other trauma related conditions. In the others, we have disassociation, personality adaptation, somatic symptoms, substance use, self harm, relational difficulties, and so on. These aren't signs of weakness, they are coping mechanisms that developed in response to pain or overwhelm. Recognizing these comorbidities allows us to see the fuller picture of someone's experience rather than treating symptoms in isolation. Next, we'll look at how trauma impacts differently across genders. While trauma is universal and can affect anyone, the types of trauma experienced, the ways people cope, and the support they receive are often shaped by gender roles, social expectations, and cultural norms. Understanding these differences helps us avoid one size fits all assumptions and ensures that our support is sensitive, nuanced, and inclusive. So let's see how gender can influence both the experience and the expression. First, overall trends in traumatic stress and mental health. Large scale studies, such as those by Kessler and team, as well as Stewart and team, show a consistent pattern. Women have higher rates of PTSD when exposed to traumatic stress, and men experience higher rates of PTSD when exposed to traumatic stress. Ling and team, women are more likely to experience physical and sexual assault, often within relationships. Men, on the other hand, experience more combat exposure and crime victimization. Location of the trauma also differs because women's trauma is often relational and intimate partner related. It tends to occur in private settings such as the home. Men's trauma, like crime victimization, more often occurs in public spaces. The relationship to the perpetrator is another key difference. For men, perpetrators are more often strangers. For women, the abuser is frequently someone they are in a relationship with, a partner, or a trusted individual. Military trauma adds another layer. As women increasingly serve in the military, they are now exposed to many of the same traumas as men. However, the rates of military sexual trauma remain significantly higher in women, again documented in the Kimmerling et al. Research. And there are emotional dynamics that research has highlighted as well. Women and girls may hear phrases like I love you during the same period the abuse is happening, which creates deep emotional confusion and attachment disruptions. Men, similarly, can experience domestic violence and sexual abuse, though these cases are often underreported due to stigma and cultural expectations. Taken together, research shows that trauma is universal, but its context and the way it's expressed often differ across genders. Understanding these distinctions helps us offer trauma-informed care that is accurate, compassionate, and grounded in evidence. All right. So now Shubhangi will be taking over.
Thank you, Harsh. So today, I'm going to talk about the essential skills, approaches, session planning strategies that are required in trauma practice. Okay, so we will be starting with the skills that are needed in trauma practice. Next slide. Let's begin with reflective listening. Trauma survivors often carry a deep sense of being unheard or dismissed. So, our job in here is to not hear the words, but also understand the emotion beneath them. For example, if a client says, I overreacted again, so a reflective response from our side might be, it sounds like that reaction felt intense and confusing, and maybe part of you feels frustrated with yourself. Okay, so we are not telling them that you are overreacting. We are just understanding the emotion beneath that. Part of them which is feeling a certain way is reacting that way, and they aren't the problem, right? This demonstrates that we are holding space for both the thought and the emotion. So when we talk of reflective listening, it builds the foundation of safety and trust, without which trauma work cannot really happen. Next is your body language of a therapist. So, clients who've been traumatized are extremely sensitive to nonverbal cues. If you are tensed, rushed, or if there is a sort of rush in your tone, or if your tone is at a higher pitch, or if you're distracted, they sense it instantly and they shut down. They'll not talk. They will not respond. Which is why our body language is more like an instrument. Our posture should be calm, our shoulders should be relaxed, our feet should be grounded, our tone should be soft, and breathing should be slow. Remember that our nervous system regulates the client's nervous system. This is co-regulation, and it is one of the most powerful tools that we can carry as a therapist. Next comes in the grounding techniques. So, grounding is crucial because trauma often pulls clients into a past memory or a threat response, right? So we help bring them back into the present moment, into a body, into a safe space. It can be as simple as feel your feet on the floor or notice five things around you, hold this textured object, describe it, very basic things, very simple. But these techniques prevent the client to feel overwhelmed and keep the client within their tolerance window so that it does not get too overwhelming for them at any point to talk or discuss about their things, right? Grounding is not about avoiding anything. Rather, it is about feeling emotionally safe for the client. So we have a perception that, through grounding, we distract the client, or the aim is to distract the client to thinking about a different thing, but that is not the case. Grounding is basically to make the client feel emotionally safe so that they can share their experiences. Then the next is understanding nonverbal cues. So, when we talk of clients who have gone through trauma, they don't really verbally express discomfort. Rather, they'll show it. They might fidget, they might look away, freeze, not share, hold their breath. They would stare blankly, or there could be disassociation, overwhelm, fear, a lot of things, right? So, a gentle intervention sounds like, I'm noticing you went quiet and your shoulders were tightened. How are you feeling right now? You know, or I'm noticing that there's something that you want to share. Would you like to talk about it? This shows attunement. It communicates that we are there with the client, we are noticing them, and they're not alone. So, understanding nonverbal cues are a crucial aspect of when we are talking about trauma, working with clients who have experienced trauma. Last but not the least in here is empathy and validation. So this set of skills, empathy and validation, is the antidote to shame. So people who are trauma survivors, they always deal with maybe guilt, shame, right? That I'm wrong, I should not have done this, or I should have done better. So when we provide empathy and validation, it is antidote to shame. That means trauma, because trauma survivors often think that why am I like this? What's wrong with me? Why did it happen with me? Right? So a validation could sound as simple as given what you survived, your reaction makes complete sense, or whatever you did in that situation, you did the best. That's the best you knew at that point, at that juncture. So when we validate, we are just not comforting the client, but we are also rebuilding their dignity, right? Okay, let's move to the next slide, Harsh. Trauma practice. So we'll be exploring major therapeutic approaches. We'll be talking about, next slide, internal family systems. We'll be talking about trauma focused CBT, trauma focused therapy, narrative therapy, exposure therapy. Now, because we have a time constraint, I will not dive deeper into it, but we do have a paid training on advanced training and trauma informed care workshop, wherein we talk about the tenets, the cores, the elements, the theories, and so on and so forth. So today we'll just be brushing through them so that we are aware what those are, but not into much detail. Okay, next slide. So first is IFS, which is internal family system, right? So IFS views our internal world as a system, okay, of parts, each holding emotions, memories, or protective strategies. So when we talk of safety building and trust, we create safety because no part will open up without it. Clients have several parts, right? So our job is first of all to create a safe space for those parts to open up and tell their part of the story, how they feel about it. If we are not able to give safety or build trust, then no part will open up. So next is identifying and externalizing parts. We have the clients recognize their parts, such as the terrified child, or this is the protector in them, this is the perfectionist in them, this is the angry defender. So when we externalize those parts, it is just not about the client now. And it helps in reducing shame because it shifts the narrative from I'm broken or there's something wrong with me to a part of me which is hurting. So so the client comes with that, okay, there's something wrong with me, I'm wrong, and now we have shifted to the narrative to a part of me is hurting or right. Then is self leadership. Here we strengthen the client's core self, the calm self, the compassionate one, the wise inner voice, which can lead the system. Then building relationship with parts, wherein we help the client speak with their parts, understand what each part fears and what it's been protecting them from. Okay. Understanding that if the client has this particular thought process, if they are reacting this way, what is the aim of that behavior? What is that behavior? What purpose is that behavior serving? Then unburdening and transforming traumatized parts. So trauma burdens parts with beliefs, such as I'm unsafe, it was my fault, I'm unlovable. IFS helps release these burdens. Then promoting integration and self compassion, wherein we finally restore harmony and the clients learn all the parts of them deserves compassion. The client learns where the concerns of those parts are coming from, why are they reacting the way they are, why do they think the way they do, right? So that helps them to inculcate harmony, right? And it gives them a realization that all parts that they have, they deserve compassion. Okay, next slide. Next, we have trauma focused CBT, which is cognitive behavioral therapy. Very quickly, I'll walk you through this. So, when we talk of TFCBT, which is trauma focused CBT, it is an evidence based, which is especially effective for children and adolescents both. It involves psychoeducation, emotional regulation skills, trauma narration, and caregiver involvement. It helps to reduce guilt, shame, and distorted thoughts and supports both the child and the family system. It also includes the families, how they can help in reducing the trauma, the shame, and change the narration and help them with the emotions that they have. So it comprises of the thoughts, the feelings, and behavior. Just it is with CBT, but it is tweaked a bit for trauma focused. Okay, next slide. Then we have trauma focused therapy in general. So this approach looks at trauma's impact across emotional, behavioral, physical, and spiritual relational domains. Okay, the aim is not to erase trauma, but to help the clients create healthier and more adaptive meanings and also coping strategies, right? So, as we said, it is more like a holistic, which takes care of all the mental, behavioral, and emotional, physical, spiritual well being. The purpose is to offer skills and strategies for coping to help them process their emotions, you know, and the memories that are tied with the traumatic experience, help them understand that, process that, come in terms with that. And the end goal of it is to create a more healthier, adaptive, and meaningful experience. Next, then we have narrative theory. Uh, Narrative therapy is basically understanding what what's the meaning we make through stories. By we, I mean the client. What stories that they have, what meanings have they assigned to it? We might have same stories, but based on the perception, beliefs, values, and everything, we might assign different meanings to those stories, or we might narrate the same stories in different way. So trauma often creates a dominant story which focuses around I'm weak, I'm unsafe, I deserved it, I'm not good enough. So through narrative work, clients re-author their story. You know, instead of focusing on the negatives, we focus on the positives. Like I survived, I adapted, I came stronger through it. I'm stronger than I realized. I endured all of this, and I'm stronger. So we also integrate psychoeducation and how trauma affects or impacts the brain, helping clients shift from self blaming to really understanding what is happening. Okay. So, we, the basic philosophy of narrative theory is that we change the meaning by organizing the memories into stories. Okay. We use stories to help change the emotional reaction to the past, the way they emotionally react to the past. And the first session basically works around helping them understand how therapy works, information on how trauma impacts the brain, the scientific thing, how the brain works under trauma, so on and so forth. So this is how we start with narrative theory therapy. Next, then we have exposure therapy, which is also known as prolonged exposure. So it helps the clients gradually and safely face trauma reminders that they have been avoiding. It avoidance maintains fear. If you all know that the more we avoid, the stronger the fear response gets, because the more we avoid something, our amygdala is instructed that it is fearful, it is something dangerous. So the more amount of times we ignore something or avoid something, the stronger the fear response becomes. So through exposure therapy, we undo that, right? Because we know that avoidance maintains fear. So we allow them, gradually help them to safely face their trauma in a repeated, safe exposure, right? Which reduces distress and teaches the brain that the danger is over, or it is not something really dangerous, right? For example, if somebody is scared of driving, first we ask them to visualize, in a safe space, or we ask them to there are mock driving that happens, wherein they're not really driving, but it is a simulation which makes you feel that you're on the road. So eventually through those techniques we aim to uh, reduce the distress and teach the brain that, okay, after all, it is not so stressful or not so scary or something, not it's not something that I should be so fearful of. Okay, next slide. Now, there are a couple of more therapies that are used in trauma informed care, such as holistic therapy, which includes CBT, DBT, psychoeducation, relaxation, family system, acceptance commitment therapy. So it is something that uh, includes everything, right? And it takes care of things such as yoga, mindfulness, breath work, somatic practices, helps clients reconnect with their bodies, regulate their nervous system, release their stored tension. This is especially useful when the trauma is stored somatically. Sometimes the body learns the trauma, sometimes the body stores the trauma in several parts. And so holistic therapy helps with that. Then when we talk of psychodynamic theory, psychodynamic work looks at early attachment patterns, the unconscious themes influencing how clients process trauma. It helps uncover repeated relational patterns and unresolved emotional conflicts. When we talk of psychoanalytic therapy, it is a deeper long term exploration focusing on defense mechanism, transference, unresolved childhood experiences. It helps clients understand the root cause of the emotional patterns which are shaped by their trauma. Then EMDR uses bilateral stimulation such as eye movements or tapping to help the brain reprocess the traumatic memories. It reduces emotional intensity and allows clients to store the memory in a more adaptive form. It is one of the most researched treatments worldwide, and with trauma, it is extensively used. And it has been seen to reduce the trauma response and make the clients feel more attuned to their present environment. Then, when we talk of eclectic approach, herein we combine a lot of approaches, right? Such as because there's no single model that fits every client. So, according to the client's need, if they need more DBT, if they need more behavioral, if they need more CBT, or if they need more mindfulness, whatever it is. So, using all and everything is eclectic approach because trauma therapy, when we talk of it, it is personalized, it is culturally sensitive and responsive to the client's needs. So for that, we need an eclectic approach. Next slide. Yeah. Then we'll talk about very quickly, we'll see that how can we plan sessions in trauma practice. Next slide. Okay. So first is asking about trauma. How do we go with that? When we ask about trauma, we always explain why. This prevents clients from feeling interrogated or blindsided. So we may say many people find the past difficult experiences affect their present feelings. You can share only what feels safe for you. So instead of rubbing it on their face and asking them that, hey, what happened and asking them about the trauma directly, just letting them know that why are we asking that, because it impacts the present feelings, and also providing them a safe space by letting them know that they can just start by sharing as much as feels comfortable for them and not push them. And at any point, if they feel that it is getting too overwhelming, they can let you know. So that provides them a safe space and also allows them to share their experiences. Making choice explicit. Choice is central to healing. We all know, right? Trauma takes away the control. And in therapy, we work on returning that control. We make it clear that you can pause anytime, you can decide the pace, you choose what to share, you choose how much time you want to, open up. So we are allowing the client, giving the client the autonomy to decide, you know. We are making the client feel that they have the agency, which trauma has taken away from them. Okay. Then questioning informally. Instead of direct questions, we invite exploration gently. This lowers the defenses and reduces overwhelm. Sometimes all we need to say is, would it feel okay to explore what came up for you? The triggers. Would it be okay for you to share about this? Would it be okay if we talk about this some more? Or would you like to keep it for some other day? Do you feel that, you are emotionally ready to discuss about this? So without directly asking them, we are indirectly questioning them, right? We are using gentle exploration. Then eliciting strengths. So when we talk of trauma, it shrinks a person's view of themselves. They think very, negatively about themselves, and they really make them into this small negative individual. So we help them see their strengths, their resilience, survival strategies, courage, and resourcefulness. This helps build hope in them and increases the engagement in therapy. Okay. Next. Now, what are the practitioner responses to avoid? What are the things that we should avoid? It is very important to understand what are the don'ts in uh, trauma informed care when we are dealing with clients who have undergone trauma. Okay. We avoid certain responses because they can traumatize. These could include asking the graphic details: what happened, when did it happen, how did it happen, all of that, right? Or confronting them. Why did this happen? What were you doing? You know, something that makes them feel confrontational, that we are confronting or we are questioning them, or minimizing their experience. Sometimes, just to have a collaborative space, we tell them that, yeah, I understand what you must have gone through. But in all honesty, we don't. We just want to understand how you're feeling. Telling them that we understand how you're feeling makes them feel that we are minimizing or ignoring their experience, right? So at times, just saying that I'm sure it must have been very difficult for you, or whatever it is, as much as I would. I mean, even though I'm a therapist, I cannot even remotely understand or be in your shoes to see what you must have gone through. That makes them feel valued. That makes them feel that the experience they have, the trauma they faced is valid, and it is not something worth ignoring. Then focusing on only on the negatives. Sometimes we just tend to just to get more information, just to understand, explore. Sometimes we just focus on the negatives, right? Then what happened? Like on the negative parts of the story. Instead, we can focus on their courage, you know, their actions, given in the fight and flight mode, in the high stressful mode, the things that they did, focusing on that, focusing on the strengths. Sometimes we also end up making assumptions that, okay, this must have happened, and which is why you must have done that, and all of that. We have to refrain from doing so. When we talk of trauma, it should entirely come from the client, their experience, how they perceived it, what happened, and no assumptions from our side, no putting words into their mouth, right? Now, making promises we can't keep. This is something that should be avoided, right? We will do this particular thing, you will forget this entirely, or it will never bother you ever again. We all know that's not true. If somebody has gone through something, there are certain triggers. And even after being in therapy or being in a safe space, there could be certain things which could trigger them and which could elicit the trauma response again. So we should refrain from making promises that can't be kept, and we should be more realistic when we are when we're talking about the sessions, the session plan, and the outcomes. Okay, next slide. Very quickly, we'll walk through treatment plan. First is establishing safety, because safety is the foundation. If a client does not feel safe with you, with themselves, or in the environment, trauma work will not progress. Then is screening. We use validated tools to assess trauma symptoms, dissociation, and risk. This helps determine the readiness for trauma processing. Then there are assessment. A good trauma assessment explores emotional, cognitive, behavioral, somatic, relational, and developmental impacts. We understand the full picture before deciding on to the next steps. Then there is psychoeducation. We explain how trauma affects the brain, fight, flight, freeze, dissociation, hypervigilance. We talk about all of that. When the client understands the neuroscience, they feel less ashamed and more empowered. When they understand that, okay, this is how the bodily responses, there's nothing much that was under their control. So that helps them feel less ashamed and more empowered. Next slide. Then we have normalizing symptoms, wherein we normalize the reactions so that the client does not interpret them as personal failures. You know, we can use phrases such as your brain protected you, your body did what it needed to survive, so on and so forth, right? Identifying and managing triggers, wherein we help the clients map triggers and learn grounding, cognitive strategies, and behavioral tools to manage them. Then we have drawing connections, wherein we connect past trauma with current behaviors, not to blame, but to make a sense of the patterns that are happening. Insight reduces confusion and increases agency. When I know what's happening, what happened, why I did what I did, it increases agency. Last but not the least, building resilience and balance. Finally, we help the clients build long term resilience through boundaries, emotional regulation, self compassion, meaningful relationships, and healthy coping strategies. Healing is not linear, which is what we tell them. It is a gradual strengthening of inner resources, right? We have in the advanced training, which I was talking about, we have more treatment plans. We have the assessment tools that can be used for trauma. We have a very comprehensive training. So if you all are interested in that, you're most welcome. Next. So over to you, Harsh.
Thank you, Shubhamji. Right. So, one second. Yeah, before we close today, we want to shift the focus slightly. We spent around the last hour understanding trauma, assessment, and treatment planning. Now, in this final section, I want to talk about something equally important while working with trauma cases. Now, I understand a lot of you might not be psychologists attending this session, but a lot of these things that we'll be talking about do affect all of us, even when we are caring of someone as a caregiver, okay, or as a friend, as a loved one. So, trauma informed care isn't just about what we do for others, it's also about how we care for ourselves so we can continue to show up with clarity and intention. So, here we will highlight the emotional load of trauma work, the signs of secondary trauma or fatigue, and some sustainable practices to protect our well being. Okay? So, when we work with trauma, our own nervous system is involved too. So, this slide focuses on how we handle our own triggers, because unprocessed reactions don't just shape us, they shape the therapeutic space. Right? Supervision and peer support are our first line of grounding. They help us notice blind spots, regulate our own emotional responses, and prevent isolation. Next is personal self care, the basics we often encourage clients to do: sleep, nutrition, movement, creative outlets. These are not optional for trauma work, they're protective. Mindfulness and relaxation techniques, even a few minutes of breath work or grounding before and after sessions can reset the system and reduce emotional carryover. Establishing boundaries is essential. Knowing when to pause, when to refer, and when to say no keeps the work ethical and sustainable. A big part of this process is self awareness and reflection, tracking what themes or client behaviors tend to activate us allows us to prepare, regulate, and respond rather than react. We also benefit from specialized training in trauma informed care. The more skilled we become, the less likely we are to feel overwhelmed or dysregulated in the room. For high intensity cases, having crisis intervention plans ensures we are not improvising in the moment. This reduces anxiety for both the client and us. And finally, regular personal processing through supervision or personal therapy helps us stabilize what we are holding. Trauma work requires ongoing emotional housekeeping. These practices keep us grounded, effective, and emotionally safe while we hold space for others. So, as we wrap up this presentation, I want to leave you with this powerful reminder from Bessel van der Kolk. In order to change, people need to become aware of their sensations and the way that their bodies interact with the world around them. Physical self awareness is the first step in releasing the tyranny of the past. This captures the heart of trauma informed work, whether we are supporting clients or caring for ourselves. The process always begins with awareness. tuning into the body, recognizing what's happening inside us, and understanding how those sensations shape our thoughts, our reactions, and our relationships. Trauma healing doesn't start with doing; it starts with noticing. And when we, as psychologists, stay connected to our own bodies and boundaries, we are better equipped to guide clients and others towards safety, regulation, and resilience. So let this quote serve as our closing message that change is possible and it begins with conscious, compassionate awareness. And with that, we come to the end of the session for today. Thank you so much, everyone, for joining us. And if you have any questions, you can ask now, and we will do our best to answer them. Alok, how to register for the advanced course? The dates are not finalized yet, but we will be sharing the instructions of the same in the group that you're currently in. So just after the session, don't leave the group and keep an eye, and we will share the details there. Yes, Dia, go ahead.
For like someone who has like trauma induced like OCD symptoms, what do you do for them? Because like if you try to process that trauma, their OCD gets worse. If you try to process OCD, trauma gets worse. So
Yeah, can you just repeat? I think I lost you.
yeah, so I'm asking like what do you do with clients who have like trauma because of some OCD because of some traumatic event?
Right. So the first of all, if we really start with the client, so if the presenting problem is OCD, right, we do some sort of medications are required. Okay. Then we give some sort of relaxation techniques for the OCD, behavioral techniques, right? However, the main work needs to be done with the trauma because trauma is the main concern. Trauma needs to be, I mean, the working needs to be around the trauma, understanding the narrative, externalizing the parts, the things that are there in trauma. Because if OCD is due to trauma and that has been established, so if we work on the trauma and reduce the symptoms, then OCD would automatically be taken care of. Till the time we are working with the trauma, it is a comprehensive part, takes time. It is a very time consuming thing to work on trauma. Till the time we're doing this, medications and some exercise and activities along reducing the intensity or the emotionality because of the OCD can be worked upon simultaneously. But the focus has to be on trauma. Did I answer your question?
Yeah, thank you.
Okay. Yes, we have somebody raise their hands. Bhumi? Uh,
Yes.
yeah, Bhumika. Hi, Bhumika, you're not audible.
Am I audible now?
Yes, yes, you are.
Yeah. So, hi. My question was for both of you. So, okay, for example, we, as a psychologist or as a, specialized in therapy, sorry, in trauma, what if we got a client who has been through a lot in their life and is carrying so much of trauma?
Who has been? I think there is some disruption in your audio. Is it just for me?
Uh,
Okay.
Harsh, can you hear her clearly, or am I?
yes,
Is it
there is
just?
some background disturbance.
Yeah,
Okay.
there is some
Am I
disturbance.
audible now?
You're
Uh,
audible, but in between, due to the background disturbance, we are not able to hear you.
Okay, yeah, just a second.
Okay. Uh, and meanwhile, anybody else?
Now, am I audible?
Yes, yes, you are.
So, what get a client who has been through a lot in their entire life, and they are carrying so much of trauma that they use coping mechanism has like humor and suicidal thoughts.
I'm
So
so sorry, Bhumika. I'm not able to hear you in between.
can I say like can I
Yeah,
text you
yeah,
the
yeah, yeah, yeah. Please drop it in the chat box, please. Yeah, that'd be better. Okay, we have more questions. Yes, Gauri.
Yes, good evening. I would
Good
like to
evening.
ask that how do we differentiate between actual traumatic events and experience that one hallucinates in their mind, or do we treat it with the same care we are doing to actual traumatic events
So,
experience?
so if I understood you correctly, you're asking how to differentiate between hallucinations and traumatic events.
Yes, the hallucination we make of a traumatic event, like a person makes them.
Hallucination makes of a traumatic event. I didn't really get it.
I'm trying to ask that if a person is hallucinating, like they are making up scenarios in their mind where they are
Mhm.
experiencing a traumatic event. So, how do
Right.
we differentiate from actual and those hallucinations?
Okay. So first of all, when we talk of when we say that they're hallucinating about traumatic event happening to them, we need to differentiate. Is it hallucination? Is it vivid dreaming? Is it flashback? We need to understand that first, right? Second of all, if it is hallucination, which means it hasn't really taken a place, if the traumatic event hasn't really taken place and it is just a fragment of their imagination, we need to work on the hallucinations. For that, we need medicines, antipsychotic medicines, right? If we are talking about real trauma happening in real life, then we need to work on the with the trauma therapy. Is that what you're asking about? How to differentiate between that?
Yes, thank you.
Yes, Sakshi.
Yeah, so my question is firstly evening. So my question is if a client comes up, okay, and we know he is for traumatic event, but he is not vocal enough even after doing certain exercises with him and even after building that rapport and everything. Yet he is not vocal enough and there is no acceptance of such events. Then in certain case, what can be done? Like even after
Okay, so if they're
using,
not
even after
opening up,
doing all
even
the
after, yeah, yeah. So with that,
yes.
the only thing that works with is allowing them their pace. What happens is that we, in our mind as therapists, we have a certain pace that, okay, these many sessions, we will make this progress, this is what we will be doing, and etc., right? But with people who have suffered trauma, with them, our main agenda is to help them to open up, help them to provide them with a safe space. And for that, we will have to give them the autonomy to decide their pace, to decide how much or how little they would be sharing. As we progress through the session, as uh, you know the relationship between the therapist and the client strengthens, as the trust builds and strengthens, that is when the client eventually opens up. I will be sharing a very personal experience. It took me 14 to 15 sessions, which is at least 4 to 5 months with the client before they really started opening up, right? So the only idea in here is to allow the client to decide their pace, because if we force them, if we try to push them, then they will not open up at all and they will become resistant to therapy. Did I answer your question?
Yes, thank you so much.
Okay. Do we okay? Any more questions? Anything else? I think there's a lot. Uh okay, I think Harsh has answered licensing. Bhumika is asking, how do we deal with a client who has been through a lot of trauma, that they use dark humor and suicidal thoughts as their coping mechanisms? If we have a faulty coping for anything, the only way is to understand what purpose is that dark humor or suicidal thoughts doing. What purpose are they serving? Is the dark humor to mask anything because they don't know how to cope? They're not sure, they do not have the resources to cope. If that is the case, we provide them with healthy coping. We help them understand what all coping strategies they have. We help them provide resources such as mindfulness, relaxation, DBT skills, whatever there. But the first thing in it is to understand what purpose is using dark humor or suicidal thoughts. What purpose is this serving? Once we understand the purpose, then we can replace these faulty coping with the healthier coping strategies. Was your question answered, Bhumika? Please let me know. Okay, we have another question from Durga. Thank you so much for the interactive session. I was wondering how should a therapist help clients who have trauma due to systemic depression, systemic. See, Durga, it's a really good question, but I would really, something that I believe in is if there is a root cause for a problem, just working on the uh, superficial level, just with the symptoms, might not work. It might help the client feel relieved for some period of time, maybe 3 months, 3 years, we never know. But for some period of time, the client might feel relieved. But then at some point or the other, they might again get triggered. So if there is some root cause, and because of trauma, the client is having some presenting symptoms, we should be ideally working on the trauma so as to ensure that it does not get triggered easily in the future and it has been dealt with properly. Basically, opening and closing the tabs in a proper way. Okay. Yeah, Reet, yes, you will get a certificate. More information on that will be shared in the group. Okay, Dhara is saying I won't be able to run on the questionnaire. How can we deal with a person who is in complete denial while we can get information of past trauma from the informant? So when we say that the client is in complete denial, we'll have to see that if it is psychotic, if it is just a defense mechanism, or what. If it is neurotic or psychotic, first differentiation has to be made on the basis of that. If it is psychotic, medications are needed, right? If it is neurotic, then we might start by understanding why is the denial, where is it coming from? Is it the fear? Is the client does the client do not have enough resources or coping to deal with it? We equip with them with that. We provide a safe space and allow the client to open and take their own pace. Okay, Dhara, was your question answered? Yes, ma'am. Okay, okay. All right. Any more questions? Anything else? Harsh, can we move to the CBT slide?
Yes, one second.
Okay. All right. Any more questions? Anything else? All right. All right, Dvija, here is your CBT slide. Dvijapriya. All right, guys, that was it from our side. If you guys have any questions, feel free to ask us. We'll be extremely elated to see all of you in our advanced training, which would be a paid training. In there, we would be talking in detail about the therapeutic approaches, about the theories of trauma, understanding what we can use in our sessions in therapy with trauma clients. And it would give us a very comprehensive understanding. We have included a lot of researches, we have included a lot of studies into developing that advanced training. So really looking forward to seeing you all there. Okay. Yes, Gauri. I would like to ask some question. Like I have case where the patient is indirectly connected to the experience in there is family that led to society disrespects. Child, how can that person help us? Okay, Gauri, you're saying, I would like to ask on the question. You have a case where the patient is indirectly connected to the experience in their family. Like, I'm not really understanding what do you mean by indirectly connected to the experience that led to society disrespects for a child. Can you explain me? I'm not able to understand this. How can the person help themselves in what sense? Am I audible? Harsh, am I audible?
Sorry, I was answering something on my phone. What was the question?
No, am I audible? I think
Yes,
Gauri
yes,
has
you
written something. I'm not able to really understand. Are you able to understand?
are. I think what she's trying to ask if, as a child or as a young adult, they are exposed to some event that affected their whole family, and their trauma is linked to that indirectly. Like they did not have any agency, any actions
Is that what
involved.
you is that right, Gauri? Did we interpret it right? Gauri, are you there?
So she says it's a case of parental abuse and domestic violence, and that parents what led
What
her
led
to
her
get
to get
upset.
assaulted in society? Yeah. Okay. When we're talking about emotional assault or any emotional harassment that happened, first we need to understand the narrative of the client, right? What issues are they facing with? How do they perceive it? Do they perceive it as their fault? Do they feel that it should have happened with them? Once we understand their narrative, then that is when we can maybe change their narrative, or we can help restore agency in them, that they are in a space to heal themselves. They have the control over their life, and using an eclectic approach, I think we can deal with that case. Actually, in all honesty, Gauri, without understanding the entire case, without understanding the family background, the dynamics and everything, it gets a bit difficult to really give a solution like that. Okay, so I think we are a bit over time. With that, we can conclude our session over here. Thank you so much for joining in. If you have any more questions, you can drop it in the group, and you will be informed about the paid training, the advanced training, and you will also be informed about the procedure for the certificates in the group. And thank you so much, guys. Have a great weekend. Take care. Bye bye. Thank you, Priyanka. Thank you for joining.